Okay, everybody, welcome back. Today we're going to be covering orotracheal intubation. It's a skill that a lot of paramedics use every single day. I know we use it quite frequently at my service. We do want to make sure that we follow our indications and our contraindications. So you as a student should be able to tell me some indications and contraindications. Just a few indications, obviously, patients in cardiac arrest, they can't control their airway, etc. Contraindications, that patient has an intact gag reflex. Let's say you're a service that doesn't carry any paralytics, anything like that, that they can RSI a patient. That would be a contraindication. Today, we're going to be going off the scenario that our patient is in respiratory arrest. It's not cardiac arrest, but just respiratory arrest. And we'll go from there following our intubation skills. So we do want to make sure we have all of our appropriate equipment. Each morning we have to check off our ambulances just to make sure that we do have all appropriate equipment and working equipment. So today we'll be using a Mac 4 laryngoscope. Show you, everybody always needs to make sure that the light works, the batteries are good on their laryngoscope every morning when they check your truck off. Next we'll be using just an airway adjunct, so either an NPA or an OPA. These are smaller sizes, and it's just for demonstration purposes only on this mannequin since it is a smaller mannequin, so we don't want to mess that up. We want to make sure that we do have the appropriate size ET tube. So again, for demonstration purposes on this mannequin, this is a 6.0 ET tube. Do have the bulb inflated because we do always want to make sure that our bulb inflates, doesn't have any leaks, anything like that prior to using it. Obviously these would all be sterile, but for training purposes, we're gonna go ahead and take them out of the package. So we do know that our balloon inflates and deflates correctly. Obviously we have a 12 ml syringe. We're gonna put about 10 milliliters of air or water for that matter. A stylet, we use the satin slips or a bougie device. So we have a satin slip stylet today. Commercial tube holder, we use the Thomas brand. Some services, I can't really name any to be honest, that use any different ones, but I'm sure they're out there. We always want to make sure we have a stethoscope, so we can also take for our lung sounds, breath sounds. Appropriate suction, and obviously a suction device. Particularly we use Decanto suction catheters, like them, think they're the best. And arguably the most important thing is a BVM. This is an adult BVM. Obviously use the BVM appropriate for your patient's age. We do have a mask that attaches to the BVM. And then I have two different CO2 detecting devices that I like to use. The first one would be the color changing that comes in the bag with the BVM, and the CO2 sampler that goes directly on the tube. So now, to begin our intubation, we know that we have all of our equipment laid out that we're gonna need. We have our patient, our mannequin. Obviously I already have my gloves on, but first and foremost, just like you're taught in every EMT paramedic school, BSI, scene safe. We know our scene safe. Obviously I have my appropriate PPE on. A lot of services that I know of now, they're going to safety glasses. So you need to wear safety glasses if that is one of your SOPs for intubation. So it's not in our case, but this is the first thing we want to do. We've already prepared our equipment. If this was a true respiratory arrest, your partner would already be ventilating our patient, right? Bagging our patient, as they say. So let's pretend that they're not doing that. And we need to start with pre-oxygenating our patient for intubation, right? So we're gonna select our OPA. Again, not appropriate size for most people, but for this mannequin, it's what we're gonna use. Okay, so our OPA is in there, it's holding their tongue out of the way. Another thing that I like to do to help pre-oxygenate your patient, and if you do any type of critical care, flying, anything like that, what a lot what this will do is pre-oxygenate your patient with a nasal cannula. In this particular case, this is a nasal cannula with the end-tidal CO2 detector, so you get both your end-tidal and oxygen delivery. So we're going to crank this oxygen all the way up. Okay, so that's going, we're pre-oxygenating our patient. At this point, I could take over ventilations from my partner. We're going to make sure we've got a good, appropriate mask seal. So I like the EC method. I have a bigger hand, so it's a little bit easier for me. So making sure that we have the airway open. Airway is open. We've got our OPA in, pre-oxygenating using oxygen. And then our BVM would also be attached to another oxygen source, whether it's the one coming from the wall or a spare tank. So gonna ventilate our patient for about a minute, approximately 10 to 12 breaths. You're gonna make sure you have good chest rise and fall. Make sure you're letting that patient exhale all their air. Okay, so that's 10 breaths. So we're going to allow our partner to take over our ventilations and pre-oxygenation for our patient. In the meantime, you, the paramedic or the person intubating, can go ahead and, I like to say, gather your thoughts, gather your equipment, take a breath, so to speak, because obviously you want to have a good first pass rate, and that means that your paramedics have to be confident in what they're doing. So calm down, in other words. So we checked our light. We know that our light works on our Mac 4 blade. We'll close that up. We know that our bulb doesn't have any leaks. It's easy to inflate. So we're gonna place our stylet just to the very end. And I prefer a hockey stick type shape. Okay. A trick that I like to do is go ahead and place my syringe on the end, but make sure that you're not pushing it, okay? So at this time, we'll have our partner stop with the BVM, remove the OPA, and then we want to appropriately open that patient's airway. Now, the best way to do that would be to place the patient at about a 30-degree ramp on your stretcher. Usually we can pad kind of some of the voids to kind of open the airway enough to be able to see that, or be able to correctly view the vocal cords. So we're gonna go in on the right side of the mouth, sweep the tongue to the left, and then without using any leverage on the teeth, we want to be able to view those vocal cords. And I do see them, and we're going in. So we're gonna go in just past where we see the bulb disappear. So without removing your hands from this tube, hold on to the tube. Pull your stylet or your bougie, whatever you're using to introduce. And you want to go ahead and fill your bulb with air and remove that syringe. Next, you can either do this yourself or with a partner, your partner. Go ahead and see if you get good chest rise and fall, okay? Now, we require at my service a few different ways to verify, like I was saying. First being your colorimetric CO2 detector. Now, obviously, this is an airway mannequin, so it's not going to change colors. I'll show you on camera though what it does look like when it changes colors when you have a real human patient. So starts out purple, you blow into it or exhale carbon dioxide, and it turns a nice yellow color. You know that you're in the appropriate spot. Number two, and what is probably the most correct, I would say, maybe correct's not the correct word, but the best way of verifying other than direct visualization would be end-tidal CO2 monitoring. These go directly on the hub of the tube and they plug into our monitor. We use LifePak 15s. These plug directly into the LifePak and give us a nice CO2 reading. And lastly, what we're gonna do, again, it makes it a little easier with the assistance from a partner, is place your stethoscope on. As your partner ventilates, you want to auscultate all the lobes of the lungs. Okay, so apex to apex, base to base, and everywhere in between. I like to auscultate the areas of the abdomen just to make sure I'm not hearing any adventitious, gastric sounds. Do I note any air rushing into the abdomen, anything like that, just to make sure that we're not, or that we're in the correct placement area for our tube. Lastly, again, I know I've let go of the tube and I said not to. Makes it easier with a partner. But lastly, we're going to secure this tube. So the tube is secured. Come around. At this point, you can either leave the nasal cannula on or you can turn it off. It's up to you. In my case, I'll take it off my patient. And depending on what your protocol states, you can use a BVM to ventilate and oxygenate your patient. Obviously, make sure it's plugged into oxygen. Or you can place them on a ventilator. We carry ventilators on all of our ambulances, so we would go straight to a ventilator. Lastly, one point that we need to discuss is suction. Again, this would be placed onto either your suction canister that's mounted in your truck or your portable suction. We use a Decanto suction catheter, I guess you can call it. I love it personally. It's great. It's got a very wide open tip. So if you do have to suction any secretions, let's say this patient's bleeding in the mouth, big wide tip so you can suction. It does make it a little bit difficult on these smaller tubes if you were to need to suction the tube. Again, you would place it in. A Decanto does not have the thumb hole, so you don't really need to worry about that. If you're using something like a Yonker, worry about your thumb hole as you're suctioning, okay? Suction no more than just a few seconds. Make sure you're back directly ventilating that patient afterwards, okay? So I believe that's about it. This was orotracheal intubation on our airway mannequin here. If you have any questions, please feel free to reach out and we'll see you next time.